So they can ask you the question, all of the following are sensorineural hearing loss except. So you should be able to know the sensorineural hearing loss, which is the presbycusis, like we mentioned, aminoglycoside antibiotics, meningitis, Paget disease, those things you do not see. Another high yield one is acoustic neuroma.
Neuroma.
But the conductive hearing loss is what you can see. So we have mentioned all this before. Then we have the Renin and the Weber. So one thing you must know here is how it is done, because you can see it in the exam. When we say exam takeaway, understand the difference between conductive and hearing loss, and also know how to interpret the result of the Renin and Weber test. So what is it telling you? When they describe this in the exam, how do you know they are talking about Renin test? How do you know they are talking about Weber? So Renin, I use the word R, ringing, like when your phone ring. So when they tell you that they put it beside the mastoid process, which is the ear, towards that area, that is ringing, Renin. But Weber is when they put it at the forehead. A turning fork is struck and placed in the center of the forehead. So you must know how to interpret this. And we have gone through that. So renin, when it is positive, it is AC is greater than BC. So remember, A comes before B. Okay, A comes before B in an alphabetical order. So when it becomes abnormal, is when B comes before A. So that is how to remember. In a normal setting, when you recite your alphabetical order, A comes before B. But when something becomes abnormal, B comes before A. So that
Mhm.
means that the negative Renin test, it shows where the that bone conduction will not be greater than the air conduction. So when there is like those cerumen impaction, those conductive hearing loss. But in Weber, it's there is no lateralization, which means the sound will be heard in the equal in both ears. But when the sound becomes louder in one ear or lateralized to the affected ear, so that means that there is a problem. That means something is going on. So when it lateralizes to affected ear, that is abnormal. But when the lateralization is equal, like both ear, no lateralization, it doesn't lateralize anywhere, no lateralization is equal on both, then that is normal. Then other things we said no, the result interpretation. Then we have talked about the Meniere's disease, reduced sodium diet. They use the diuretics. Okay. Then cocaine can cause nosebleed. That is what to remember here. Cocaine can cause nosebleed. Then nasal polyps is also high yield in the exam. Nasal polyps. So what do we need to remember here? It is always caused by a chronic inflammation associated with asthma, recurring infection, allergies, drug sensitivity, or certain immune disorder. So know the cause, because chronic inflammation, if they give you example, patient have asthma, with asthma, if there is a lot of chronic inflammation, this patient will be at risk of nasal polyps. So it's a soft, painless, benign growth on the lining of your nasal passages or sinuses. So very high yield in the exam. Then we talked about mononucleosis, and I told you to use the mnemonics HEM. Everybody likes HEM. So what is HEM? H is heterophile antibody test. M is monospot. But let me tell you, monospot and heterophile antibody test, they mean the same thing. It's either you call it heterophile antibody test or you call it monospot. Then E is the Epstein-Barr virus. So what else do you need to remember here? For these patients, if they have to play contact sports, they have to check their spleen to make sure that there is no splenomegaly, because if not they will be at risk of what? Rupture. So
Rapture.
it's very important there is no splenomegaly. Make sure that the spleen have returned back to normal 4 to 6 weeks. So another important thing here is with mononucleosis, you are going to, when you differentiate it with strep throat, mononucleosis will have fever, sore throat, buzzword, posterior. So this is going to be posterior cervical lymph node enlargement. We call it posterior lymphadenopathy. But when you talk about strep throat is going to be anterior posterior lymphadenopathy. And mononucleosis, we don't give them 3 A's antibiotics. So do not give them 3 A's. What are those 3 A's? Amoxicillin, ampicillin,
Listen.
augmentin, because the
Empty.
problem is that it's going to cause morbilliform
Oh,
rash. Morbilliform rash is not a true form of allergy, but yet it be something you have to monitor and try to avoid it with mononucleosis. So mononucleosis treatment, we have it here. Then we talked about it. Then otitis media, when we explained the otitis media, we said it starts with otitis media, acute otitis media. There is what? Bulging of the tympanic membrane. What else do we see in otitis media? We say that there is immovable tympanic membrane, immovable. It doesn't move. So that buzzword, immovable, immobile. So, and otitis media, acute otitis media is always associated with the organism, the strep pneumo, the Haemophilus influenza, and the Mozzarella catarrhalis. Another important thing is that it's always children, second-hand smoker, or children that are daycare. But how do we treat our otitis media? We say start them with amoxicillin, tell them to follow up um, 48 to 72 hours. If the symptom is getting worse, change the amoxicillin to augmentin. They can also come back in 3 months. If the symptom is getting worse, to give them augmentin. But if patient is allergic to augmentin, give them azithromycin. So then when this patient comes back, this patient may be at risk for two things. The first thing is they may have otitis media with effusion. When these patients start complaining that I feel like fullness inside my ear, it's like a fluid collection behind the eardrum in the middle ear. There's no signs of active infection, but this patient will tell you, I feel I have that fullness. So what do? We can do wait and watch and wait, or we can give them antihistamine, Zotec, to be able to dry the fluid. But then if this patient comes back again, because this otitis media with effusion, after 3 months it can lead to another situation we call rhinosinusitis. Yes, because this patient can now start complaining of facial pain. When you tell them to bend, they say, oh, I have a lot of pain bending down and all that. So that is when we also give them augmentin. This patient can also come back and have what we call tympanic membrane rupture. The patient will tell you, oh, when I was lying down today, I feel like some drainage coming out. So that is tympanic membrane rupture. The treatment is watch and wait. Then we have the otitis externa. The treatment for otitis externa, if you remember our mnemonics, OOO, CCC, PP. So what is that? Otitis media, ophalosin drop, corticosporin drop, and ciprofloxacin, polymyxin, and the organism is Pseudomonas aeruginosa. So you need to know the organism for otitis externa, and with otitis externa, they have like that outer ear pain. We say that is also called pain where are the tragus. The tragus is that small, rounded, fleshy part of the external ear. So this here, we always encourage them to avoid, because sometimes, like we call it swimmer's ear, that might be the cause. Okay. Then swimming. Also, sometimes diabetes can also cause that. Then we have the peritonsillar abscess. We talked about that already. Remember the four Ds: dysphagia, dysphonia, difficulty swallowing, difficulty talking, drooling, or saliva. And we said that these people, they have like a bulging, or which is displaced uvula, the next D. So it's gonna be difficult for them, and they have a hot potato voice. That is that dysphonia. Then we have the sinusitis and eye problem. So sinusitis, which is what I have talked about, sometimes they will complain of that facial pain. Okay. Then we have the blepharitis. Blepharitis is like the foreign body sensation. It causes itching, crusting around the eyelashes. So the treatment here is Johnson baby shampoo. For the cataract, we say that is opacity of the lens, and they are going to find it difficult to see the headlight of the upcoming vehicle. So, opacity of the lens, and or you can say cloudy opacity in the crystalline lens. It happens due to aging. So, the risk factor: 65 years, smoking, diabetes, long term steroid use. So, of course, this patient will be referred for surgery. We have talked about conjunctivitis, the three type of conjunctivitis: allergic, viral, bacteria. Under allergic, we say it start bilateral, and we say that the allergic is present with stringy or rope-like mucus. It has cobblestone appearance, and we also say that with allergic, the treatment is antihistamine, decongestant, and mast cell stabilizer. Don't forget mast cell stabilizer. Then with viral has, it starts with unilateral but then goes to bilateral. And viral is a watery or clear. They have a discharge, clear discharge, and the treatment is antihistamine and decongestant. Then we have the bacteria. Bacteria is usually mucopurulent exudate, and it starts unilateral before it goes to bilateral. And another important thing is that the bacteria, it can give them polymyxin B drop, and the erythromycin drop. So this is all we talked about: types of conjunctivitis, the treatment, we mentioned it. Always differentiate the two. Then the mast cell stabilizer is what we give for allergic. Then the corneal abrasion, I mentioned we use the wood lamp. It looks like there is a scratch in the cornea. But when we use the wood lamp to see, we are going to have a round, we said it's round and irregular shape. So that is corneal abrasion. And corneal abrasion, do not use steroid. We don't use steroid drops. What you only use is the antibiotics drop or something for pain, but no steroid drop, because with steroid drop, you're going to max it, and then you're going to eventually make it worse. Okay. So that is your corneal abrasion. Dacrocystitis, we say that it is the blockage, or the blockage of the inner canthus, the teardrop. And we said for here, when you want to clean, you are going to clean outward towards the nose so that you avoid spread of the infection. So another important thing: open angle and close angle glaucoma. We talked about it. Open angle, from the word open, is less severe. They already know that they have glaucoma. They are monitoring their levels, intraocular pressure. But when it's greater than 22, you can now refer them. But with close angle, the word close, C, you are going to close the door and send the person to ER. So here they are going to have mid dilated pupil, cupping of the optic nerve. They are going to also have raised intraocular pressure, and we say that it is acute, sudden. So we have the Hesbank test. So always know that the Hesbank test very high yield. So we also use it to how do we do that? You shine light into the patient eye and compare cornea light reflexes to determine any misalignment. So like outward deviation or inward deviation. We talked about Huliedum and its tie. So when it's hotting, patient have pain. But when it's chilling, which is cheliason, when it's chilling, patient when it's chilling, it's cheliason. But when it's hot, when it's painful, it is Holiedum. Macular degeneration is high yield for older people. This is the number one cause of blindness in older population. So, what is the cause? We don't really know much of the cause, but it can be related to old age and smoking. Smoking is the number one thing, but then it has to do with old age. So, it's just a progressive eye condition affecting the macula. So, what do we need to know here for the exam? We give them Amsler grid. Amsler grid. So you need to know the three cranial nerves that helps in eye movement, which is the 3, 4, and 6. Oculomotor, trachea, and abducens. They help with extraocular movements. We talked about papilloedema. We said that papilloedema, you have to rule out brain tumor, head tumor, intracranial bleeding, intracranial hypertension, and uncontrolled hypertension. So, how do we describe it? It is always swollen, increased intraocular pressure. It is swollen. Then we have the strabismus. It can also cause diplopia. Amblyopia. Amblyopia is lazy eye. So we talked about that. So in amblyopia, you try to give them something to patch the good eye so that that eye that is lazy can be able to work. Then we have the retinal detachment. We say that it's a painless but sudden. It looks like there is flashes of light, floaters, reduced peripheral vision. So treatment of retinal detachment is to refer them. And uveitis is a eye condition we said that is associated with what? Autoimmune disorder. We differentiate it from conjunctivitis because here it has to do with autoimmune disorder, is severe redness, there is no drainage. You have to treat the autoimmune disorder like rheumatoid arthritis, ankylosing spondylitis, lupus, but um there's no drainage, is super red, severe redness, and we also call it iritis. So you can continue from other videos in the website. So